They are there and I'm low.
Okay, good evening, everyone. Welcome to this Wednesday's FRCS teaching from our mentor group. Tonight we have the pleasure of having really two big bosses here. Our senior mentor, Mr. Mahaluximavala. He is known in the group. He is a consultant lower limb surgeon, and he's been supporting this group since the start. He's given a lot of teaching here, and he's elsewhere also. And also we have Shwan. Tonight's session is slightly different. It's going to be a clinical session. So we will have an examiner, who is Mr. Mahaluximavala, and we will have a patient, who is Zobin, his registrar, and we will have a candidate, exam candidates, who will be one of you. So I know exams coming soon, and we will give the preference to people going for the exam. It will be very good practice for you guys. So please, whoever is interested in taking part, raise your hand. Next to your name, there will be a hand symbol. Please click on it so I can know you're interested in participating. And we will give you immediate feedback. And there's not going to be any timing. Exam, and come in here to your room. You are doing intermediate case now, and come in and.
Lovely. Okay. Thank you, Firas. Thank you, Shwan, for being there. For everyone, as you know, this is the first we've done. Last time we managed about, I think 6 or 8 weeks ago, we did the history. And then we started on clinical examination. And we said, let's try clinical examination for this group. It's going to be difficult, but I think it worked well last time. We won't do it with time, like Firas said, because we wanted to really, there are hundreds of books, there are hundreds of videos of clinical examination. But what me and Firas and Shwan will always try to say, this is geared for you, and it's your talking. So individually talk, and I'll try to make it as simple as we can for the knee examination. So if we go slow, and we'll do it for about 1 hour, 10 minutes, and if we don't complete the clinical examination, it doesn't matter, we can do it the next day, but we have to be as thorough as we can, and that's the basis of this. Okay? So let's be thorough. There's no quickness about this today. Samir has come to my FRCS Auth course. I'll do a little bit of that, and it's exactly what I do there, but let's try to do it in this webinar. So I'll just start now. Just to recap for everyone, Samir, do you want to just tell the group, it's your intermediate case, and this gentleman is sitting here. So now he's sitting on his chair.
Okay.
Can you see him sitting there? Yeah?
Yeah.
Okay. And this is real life for all the candidates, okay? So this is your intermediate case. You've taken a good history for 5 minutes, and I'm telling you as examiner, yes, Mr. Mansukhani, please carry on with your clinical examination. He's sitting exactly like this. So carry on and say what you're going to say.
Yeah. Hi, I'm Mr. Mansukhani. Is it all right if I examine your knee? And
Yes.
Can you please remove your trousers, socks, and shoes, and pass me your shoes? And do you have any walking aid?
Yeah, I've used a stick.
Okay, good. So Samir, can I stop you there for a minute?
Sure.
For all the candidates, this is just the recap. Like I said, Samir came to my course last week, so it's a good that he started off. So for everyone, I'm telling you, please accept this is the best opening line for any lower limb case, okay? So for any lower limb case, you're going to sit there and say, hello. Don't say your first name, say your surname, Mr. Please, can I examine you? Don't wait for an answer, but say, is it all right if I examine your left knee? Please remove your trousers, your socks and shoes, and pass me your shoes. And immediately in the next breath, do you have a walking stick? So this way you will never forget walking aids. Clear, everyone? Yeah. Now, Samir, you carry on. The shoes we did last time. So I don't want to repeat the shoes because it's there in the last clip. Okay.
Okay.
So at this stage, Samir, the shoes, you will pick up the shoes and you will describe the shoes. And by then the patient is ready and waiting for you, completely exposed with his underwear on. All right.
Yeah.
So he's here now. So let's carry on. All right.
Yeah.
So what do you want him? He's standing up now.
Yeah.
Okay, what do you want him to do?
Yeah. So while he's standing there, I look at his knee from the front, from the side, and from the back. So while examining it from the front, I look if there's any swelling, if there's any wasting of the quadriceps, or are there any scars or sinuses, and is there any obvious deformity or shortening which is apparent?
Okay. Now for everyone, we always think that we are, and this is your practice for all of you, that we go through books and like Samir said, he's talked. But Samir, if you don't mind, what I want now, which is the difficulty for all candidates and for you, is whether we should talk or not talk. All right? You agree? That is one of the controversies. And how much should we talk?
Okay.
So we are on to inspection now. So from the front, imagine this patient has a swelling. Patient got a varus, right? You have to imagine some things. It doesn't matter if it's a real patient or not. For all other candidates, I want you all to speak in a particular manner. So just tell me this. So imagine you've got a swelling in his knee, you got a varus of his knee, and you got a midline scar of a knee replacement. Okay.
Okay.
So you tell me how you're going to talk.
On inspection from the front, he's got a swelling which is around his left knee. He's got a scar which is healed by primary intention on the anterior aspect of the knee, and there is no sinus. And he's got a varus deformity, which is obvious, and there is no limb length discrepancy. Moving on to the side, there is.
We will come back. So when you're moving on to the side, have you given him instructions? Or
I'm moving around him. I'm asking him to stand there.
Okay, fine. So let's stop there for just 1 minute. For all the candidates, there's not controversy, but each one of you stick to one thing. Either you walk around for every patient, which is foot, knee, or hip, or you make the patient turn around. Firas and Shwan, any tips on this, or what should we leave it to them, or should we tell them what to do? I personally make the patient, I give a command to the patient to say, face this wall, face that wall, face me. I do it like that. You think you should advise them one way or the other?
My preference is the same, to make the patient turn around. You might be in a room which is very small. It's more difficult for you to get around, and you look awkward as you're trying to move the chair out of the way to get around. It's better to get the patient to turn.
Firas, your view?
I think it would look more professional if the patient moves. However, you judge it sometimes by the patient. If you think you're getting that patient who is not very cooperative and you're having difficulty moving and things, you don't want to waste time with misunderstanding, you could move around them. But generally, it's better, more professional to make the patient move.
So let's accept what Firas is saying, but let's say 90% of the time, stick to one. So Amir, you've said it very well. I don't mind you moving. It's not hard and fast, but let's imagine, Samir, that you are not moving around. What order will you give him? Now you want to face, so it's a left knee. So what do you want to do?
Yeah, so if you could turn to your right side.
Yeah, so that's, So can I stop you there, Samir? For all patients and for your information for the candidates, try not to ever say left and right, right?
Yeah.
Always say, please face this wall. Or face that wall, or face me. Clear?
Right.
And even if you're in the future telling him to do Trendelenburg test where you're going to stand on the left, and don't say left or right, it will always be good leg and bad leg. Clear for all the candidates. So the little small tips like this make you talk much more professionally. Okay. Otherwise you get confused. You say left, he says right, you're fooling around. Right. So Sami, just tell him, please face that wall.
Please face that wall.
Yeah. Now he's there standing like that.
Yeah.
He's a bit like this. So now you can see everybody. Firas, is the knee visible?
Yes. Very nice. Clear.
Okay. So carry on, Samir.
Yes, and from the side, I can appreciate that he's got a flexion attitude of the left knee. And moving on to the back of his knee. Excuse me, sir. Could you turn to that wall? So from the back, there is fullness in the popliteal fossa with wasting of the hamstring and gastrocsoleus muscles.
Lovely.
Sir, if you could face back, looking towards me, please.
Yeah.
And I'd also see if the pelvis level is the same level in this go.
Okay.
Yeah.
Correct. So Samir, you've done very well. And like I said, I'm just for the others. So what have we done so far? And this, if you want to write down or you want to take some tips, because this is not going to be there in any textbooks. It's an amalgamation of what is there in textbooks. Is that my way is that when we start from the front, let's start. In my mind, I divide my examination of any joint into 3 parts. The first is swelling and wasting come together. All right, Samir? Yeah. So
yes, swelling and yes.
And second big heading will be scars and sinuses, and third big heading will be deformity.
Deformity.
So from today onwards, for all of you, whether it's your hip or a knee or your shoulder, you will start by saying. So Samir, you'll stay there. You'll start by saying, in his left knee, there's swelling of his left knee, and remember, swelling and wasting go together. And immediately the next word would be there is or there is not quadriceps wasting. Clear?
Right.
Very easy. Then you'll go on to your scar.
As if you are in the real FRCS exam, yeah?
Okay.
Okay. So Ajay, this is a continuation of, imagine you were Samir and you've seen a scar in the front of the knee, right?
Okay.
Or it's a scar anywhere in the body. So this is a good short case. You'll have a scar of a non-union. You'll have a scar, somewhere in the humerus. So this is a scar. So he's standing in front of you. Again, he got a midline scar. Just describe a scar. What do you say about a scar?
Yeah, I can see a midline scar on the left knee on the anterior aspect, and the scar is well healed and no features of acute infection or inflammation. And it, looking at it, it seems to be a surgical scar which is healed by primary intention. And I can't see any features of sinuses or any infections. I want to I want to get the I'll talk to the patient. Is it okay if I ask any tenderness of the regarding the scar region?
Yeah, don't worry. That was very good, Ajit. So coming back to scar for everyone, the way we do scars is that first of all describe where in the body it is. So and there are some classical scars. If it's a classical scar, you need to say the name. So what is your classical scar in the knee called? It's a midline incision. Is that correct?
Midline. Yes.
And then in the anterior aspect of the knee, and it is of 12 centimeters or 14. So we'll talk about where it lies in the body. If it's a classical scar like a deltopectoral or a bra strap incision or a lazy S or a Smith-Peterson, you would be saying that directly. It's a Smith-Peterson scar, it's a lazy S scar, it's a bra strap. You clear what I'm saying, Ajit? Yeah?
Yes.
And now next you'll say it is 12 centimeters. Now the next thing for everyone, just say it's healed throughout its length by primary intention. Okay, just use that word. Suppose it's healed in the top part by primary intention and the lower part by little puckering. You will say it is healed by primary intention throughout its length, but in the lower end of the scar, I notice it is healed by secondary intention with surrounding redness with a sinus. Clear? Or is healed by secondary intention, but there's no sinus and no surrounding. Don't use the word acute infection and things like that, Ajit, because you're not going to get a patient like that, right? All you're going to say is it got a sinus? Is there surrounding redness? You agree?
Yeah.
Yeah. So let's use the two words. There's a sinus and there's no surrounding redness. So there is surrounding redness and it's healed by primary intention or secondary intention and the name of the scar. Clear?
Okay.
Yeah. Firas and Shwan, is that all right? Anything else you'd like to add?
No, absolutely correct. Keeping it succinct, the only criticism I had with Ajit was you repeated yourself. There was no need.
Yeah.
Healed by primary intention, well demarcated anterior scar with no sinus. That's tip. Finish.
Yeah, correct. Exactly. That's exactly what we are trying to say. That the words coming out, you have to write down what we are saying, and it doesn't matter if me, Firash, Swan say it. Can you say it in 30 seconds or maybe 10 seconds? Yeah, and your words, your writing, your words. So write it down and repeat it. And now, Ajit, carry on. imagine that we've done the scar.
In the standing view, I can see a significant left side knee varus deformity. And it's about, by inspection, it seems to be like 20-degree varus deformity. And and looking at the lateral view, also there is a.
No, don't worry about it. That's fine, Ajit.
Yeah.
Just for everyone, Ajit, like what Shwan will agree with me. You said it right, but we can just be very short, very succinct. There is varus of the left knee compared to the right. Don't worry about using the word significant. Don't worry about using the word 20 degrees. You can't really measure it. Don't say things which are not true. So my personal opinion would just, and don't use the word deformity because it could be attitude, etc. Right? So just say there's a varus of the left knee compared to the right, or there's valgus of the left knee compared to the right. And I would not say anything more because you need to move on. And you're saying things correctly. Agree, Shwan, Firas?
Yes, yeah. You have to be very focused again with this one. You might think you have time, 5 minutes for examination, but there's very little time and you have to go through it quickly. So be as clear with your instructions to the patient, as clear with describing your findings to the examiner. So there's no, examiners fully understand what you mean and you don't have to guess what you meant.
And whether 15, my 15 is your 20, your 25. So don't go into that, Ajit, right? Happy with that, Ajit?
Yes.
Yeah? Okay. Now, Ajit, what do you want him to do? You want him to turn around. So tell him, give him the instruction to face the wall.
Yeah. Would you mind to turn on this wall, please?
Yeah. Turn around. Okay. Now Ajit, he's like this. He's there. Yeah.
Yeah. I can see a flexion deformity compared to the right knee, and his ankle is also, I can see, a little bit equinus position. He's keeping, so it could be functional equinus position because of his suffering from flexion deformity, and it's about 15-degree flexion deformity.
Of what? What are you talking about? Knee or the ankle?
Flexion deformity of the knee.
Okay, fine. So once again, Ajit, very good. I think you picked up two good things, which Samir did. But so from the side, for everyone, just to recap again, from the side, what are my three headings again, Ajit? What are the three headings I have? Swelling, wasting.
And wasting, scars and sinuses, and deformity.
Right. So now you're very right. From the side, we are all orthopedic surgeons. We know that 90% of the time there will be no swelling or wasting on the side of the knee. You agree, Ajit? So you didn't mention it. So don't mention it again. You agree that most of the time there will not be any scar on the lateral aspect of the knee. So don't mention it again. But deformity you have to mention. So once again, I'm sorry, I missed. What word did you use when you started? You said there's a flexion what?
Flexion attitude.
Right. So did you use attitude or use deformity? Yeah.
I use deformity seriously.
Right. So let us all agree. It's not bad. I'm not saying it's wrong at all, but just to be safe, let us all, if you're inspecting, let's use the word attitude. So there's a flexion attitude of his left knee. Are you happy with that, Ajit?
Yes.
Okay. So use the word flexion attitude left knee. And then you go and look down, look at his foot and ankle. If the foot and ankle is absolutely flat on the floor, what is the phrase you will use?
Plantigrade.
Plantigrade. So you will say, yeah, correct. So you will say he's got a flexion attitude of his left knee with a plantigrade foot. Happy with that, everyone? And Ajit? Yeah.
Yes.
Now, if he had, like you saw, he was holding his ankle in equinus, don't worry about anything about the amount and don't give the explanation. Just say he got a flexion attitude of his left knee with equinus at his ankle. Happy with that, Ajit?
Yes.
So repeat it again. Just repeat that statement. He got a
equinus. He has a flexion attitude at the knee, and he has a foot equinus attitude.
Is it foot in equinus or is the ankle in equinus?
So sorry about that. Its knee is in the flexion attitude, and his ankle is in the equinus position.
Yeah. So, and that's all you'll say. Firas and Shwan, you agree? Keep it short there as well.
Absolutely. If I was the examiner and you said deformity, the first question I'd say is, how do you know it's a deformity?
Fantastic. Thank you, Shwan. Yeah. You see, so don't get into controversies where you have to get out of it. Happy with that, Ajit?
Yes.
Yeah.
You can always, if you say something, but you could always withdraw from it. If you said deformity, you're not sure, say, I'm not sure it's deformity. Maybe I will confirm that with my examination later on.
Yeah.
So if you said something and you want to withdraw it, you could always do that. Yeah.
But more importantly, I would just say you write down and don't even say anything else, you know. And but if you make it my mistake, like Farah said, just withdraw it. But don't do it as intentional mistake. Just do it that you'll say attitude. And like if you made a mistake, Farah is very right. You can just withdraw whatever you want. No one's going to hold anything against you. And I would say, Ajit, do not give in a clinical examination. This is, I'm telling you as just direct advice. Please do not give explanations for anything. We do not want explanations unless we ask you as examiners, okay? So you are not to give an explanation that the equinus was due to this or the other. If I ask you, please volunteer it. Otherwise, just give your inspectory findings. Happy with that, Ajit?
Yes.
Yeah, you're not going to score any more marks because you're losing time and giving me a minute and a half of something which I wasn't on my grid to mark you. You understand? Wasting, scar sinuses, and deformity. So say again what you see.
So I cannot see any scars or sinuses. There is no swelling.
Yeah.
I can see that he has got his knee in a fixed attitude, in a flexion attitude position.
Can you say flexion attitude from the back?
No, not. Well, he was holding his knee in the flex position, so that's why I said it.
No.
Yeah, you can't say that.
You can't say it from the back, right?
No.
Yeah. So what I'm trying to tell you is just, let's go back to, just because this is not in any textbooks or anything, what we tend to do, like MRCS style, and we all do it, we try to just repeat the same thing. No scars, no this, no that. Try to, in your mind, compartmentalize again that on the balance of probabilities, at the back of the knee, the correct orthopedic word would be swelling or fullness in the popliteal fossa. That's what you expect, right? So if you say there is or there is no, so let's imagine there is no swelling. So just say there is no fullness in the popliteal fossa. See it?
There's no fullness in the popliteal fossa.
Now that sounds a little more, you know, that this guy is sounding more knee oriented, like a, you know, rather than just saying, oh, there's swelling sinus like a MRCS. That's all I'm saying. And you agree that in my heading, you always, whether it's the deltoid or it's the humerus, you will always say there's no or there's associated muscle wasting, right? So you can say there's no fullness in the popliteal fossa, but I notice there is hamstring wasting and there's calf wasting, right? Or there, yeah, so say it.
So there's no fullness in the popliteal fossa, but I noticed that there's got some wasting in the calf.
Calf or hamstring. Stick to it. This is, you always have it. So write it down if you remember. So you're always going to, you know, the thigh, the hamstrings and the calf, right?
We can't.
You know, scars. So let's not say anything about scars. And as you know, there's not much of a deformity you're going to see from the back. You agree? Because you already talked about it from the front. So you don't have to say it again, right? So now you make the patient turn around again in front.
Okay. Could you please turn around for me?
Yeah, turn around, Zabin. Now you can see the knees now.
Yeah.
Now for everyone at this stage, you have to inspect the joint above and the joint below, right? So Atif, just verbalize how are you going to, you've talked about the knee, you've done the front, back, side very well. And now how are you going to finish your inspection by doing joint above and joint below. So how are you going to talk about the pelvis? What are you going to say? What is a phrase coming out of your mouth?
So I'm going to say that the pelvis is is at an equal level.
Yeah, just say, no, talk. Say, imagine it's your exam, you're talking to me and Firas and Chuan.
Yeah. So the pelvis is an equal level. I cannot appreciate any scars around the hip. There is no.
Yeah. Okay. So what I would just say is that when we talk about inspectory finding of a joint above and joint below, I would really say don't get much into the inspectory findings of scars unless it's there. Of course, say it. But the only thing which will most likely be there is the deformity, right? And that what you said was correct. Just say the pelvis appears symmetrical, or your phrase was right. But stick to one phrase, yeah? So what phrase are you going to say? The pelvis, what is your phrase? The pelvis?
So the pelvis is at an equal level?
Equal level, yeah. Now you stick to that. It sounds good. It's your phrase, but don't change it tomorrow to something else. That's what I'm saying. Yeah, that's very nice. And then if you notice scars in the hip, you say, but otherwise let's not say that. And what about the foot? How are you going to talk about the foot?
So the feet are at an equal level as well, and I cannot appreciate any deformities around the ankle.
Okay, so in the knee problem, what associated common foot problem would you associate with a valgus knee? For example, let's say it's a 19-year-old girl with a valgus knee. What would she probably have in a foot and ankle?
So she could have
she'll have a collapsed arch, you know? She might have that, very likely. Flat feet?
Yes, you could have a flat feet, yes.
So therefore you can say, I notice that the feet are satisfactory and there's no particular collapsed arch. You know, that's what you're looking for, right? Happy? So we've done your inspection. Now what you want him to do, it's your turn. You've done your inspection very well. And we either nod or we don't nod, but you said all this. What do you want him to do now?
So can you take a few steps for me? Can you turn around and walk towards the wall and come back towards me, please, again?
Okay, so he's there exactly like this. I know it is a little difficult. He's standing so far from the camera.
Yeah.
And so give him an instruction. Give him clear instruction. What do you want him to do?
Okay. Can you turn around and walk towards to the wall and then come back and walk towards me?
Walk with the limb. Yeah. Okay. Yeah.
So I can appreciate that he's walking with an antalgic gait, as demonstrated by a short stance phase.
Okay. Carry on. What do you want to do? He's walking towards you. You told him to walk towards you. He's walking towards you.
Can you stop now, please?
Yeah. And then what do you want him to do?
Okay. So I've already verbalized that he's walking with the antalgic gait. And can you lie down for me on the couch, please?
Very good. Thank you, Atif. Atif, just a point for you. You did it very well. So please understand, this is exactly what I want everyone to do. Control the situation, and Swan, Firas, all examiners will tell you. We want to see you control the situation, all right? We do not want to, it's not you're being arrogant. You want to control it like you did. You decide that can this guy walk in the room or not? If there's a chair in the place, please go and move the chair. If there's an examiner there, please tell the examiner, please move away. Give very clear instructions to him. Yes, please walk. What I tend to do is I tend to make you start going as far away from the patient as you can. Don't make him turn and walk away. That confuses him. Say, please walk towards me. Yeah, that's the best advice to give. He walks towards me. And when he comes as close to you, say, please turn around and walk towards that wall, right? Like you said. And go from the side and watch him. And then don't talk to the examiner during that time, because if you start using words like propulsion and this and that, what will happen is that this guy is walking around the room not knowing what to do. So you finish his walking, tell him, thank you very much, lie on the couch, look at the examiner and say, he got an antalgic gait. Are they happy?
Yeah.
So do that, repeat it again, just say, walk towards the wall. Just examine, no, do it. No. So tell him, he's not there, but just say, what are you going to say? Walk towards the wall, walk towards me.
So can you please walk towards me and then walk towards the wall?
Then turn around, give him clear instructions. I want to see that, Atif. Turn around.
So walk towards me, turn around and walk towards the wall.
Yeah. And you're going from the side. Yeah. And then what are you going to tell him? Say, thank you very much.
So thank you very much. And
lie on the couch.
Yes.
And then immediately look at Shwan and tell him, this patient
has an antalgic gait.
Right. But you can't take your time in this. You have to be very quick. Yeah. So, but the next advice to you for the clinical, and this I'm telling you, as I've done, you know, I've given my course for 10 years. I've been with Kevin Sherman. I've been with all the examiners. In the short case or in the intermediate case, your marking is just identification of a gait pattern. Your theory about whether it's a foot propulsion, whether it is a, you know, short stepping gait, that description is going to be tested on your Viva station. Okay. But I don't want any of you all to go into this long, you know, spiel about this is there, short that, unless you're asked. If you're asked, say it. Otherwise, just identify it like you did. Okay. Johan and Firas, that is my view. I don't know. Other people may not agree, but I think that is
perfect.
So,
nothing to add, really. I think I just want to say, sorry, Shwan. Go ahead, Shwan.
No, after you first, so please.
No, just simple thing I want to say. You can't show that, obviously, during this video conference, but I would recommend that's if you're describing deformity of any part, that your eyesight should be at the level of that part. So if you're describing a knee, you bend down actually to the level of the knee. You're describing the hips, you bend down to the level of the hips while you're looking at it. Just so the examiner, it's like a driving test, you're showing them, you bending down or you squatting down to that level. As you're describing the deformity of the knee.
Absolutely.
Yeah.
In terms of, just one other thing about when you're describing gait steps and things like that, you can get yourself into a lot of trouble in a clinical scenario. Just use succinct words, just like we talked about in the SCAR. Just, this is the normal heel to toe pattern, or normal antalgic gait, Trendelenburg gait, and leave it. Don't explain it. Don't do anything, because that's, if the examiners want you to describe it, that's where the marking is. They'll ask you.
Yep. Thank you.
Otherwise, move on to the rest of the exam.
Thank you, Sean. Thanks for ratifying that. It is something which you agree. All the candidates, you're always worried. You're always saying, let's say this more because I'll be impressing them. Believe me, you're not, because you're going to say something wrong because you're so stressed. I want you for 5 minutes. I just want you to describe just the gait pattern, like Shwan says. One is antalgic. Just tell me what you mean by antalgic gait. That is a short.
Antalgic gait means that the stance phase is shorter.
Lovely, fine. So let's keep it like that, a simple one, that the stance phase is shorter. What is the second most commonest orthopedic gait? So just give me one.
Trendelenburg gait.
Okay, so now please tell me and my co-examiners, what do you understand by Trendelenburg gait?
Trendelenburg gait is you're examining the abductor mechanism. So the abductor mechanism includes the pivot, which is the hip joint, the lever, which is the bony structures, the head and neck, and the greater trochanter, and the muscles there, which is the gluteus medius. So you ask the patient first to stand on the bad side. I mean, start to stand on the bad side. Yeah. So when the patient stands on the good side. When the patient stands on the good side, the opposite side's pelvis tends to dip down, but that's prevented by the ipsilateral abductor mechanism, and as a result, the contralateral pelvis lifts up. Whereas when the patient stands on the bad side, the contralateral pelvis dips down due to gravity.
Okay, I mean, what you said was right. I would say try for a clinical scenario. When we ask you, when you say it was a Trendelenburg gait, I'm going to ask you why. You don't have to go into the explanation, if you don't mind, Ranjit, about the pivots and things. Just say, when a patient stands, and a little tip to every candidate and yourself. Always, if you're going to explain something difficult, could be working length of the nail, could be a tension band principle, just say what happens normally in life, okay? So just tell the examiner, when the patient stands on the normal hip, the pelvis of the other side lifts up, and that is normal. You agree, Ranjit?
Yes.
In about 5 seconds, I've said what you said, yeah? When a patient stands on the normal hip, the pelvis of the other side raises. That is normal. Then say, when the patient stands on the bad hip, the pelvis of the other side sags. This is the basis of the Trendelenburg test. Then if I ask you what happens, then you explain, right?
Yeah.
Clear?
Yes.
Now, what is the third commonest orthopedic gait?
The short limb gait.
Yeah, let's be simple and let's stick to bilateral Trendelenburg, which is called waddling gait. Everyone happy? Yeah. So that's a common gait we see in the older population, right? So a person walking towards us waddling, you say this is a waddling gait. Potentially, this could be a bilateral Trendelenburg. Happy? So you're talking sense, yeah? Fourth will be a short leg gait, right? That's what he said?
Yes.
Yeah, please tell me, what do you understand by short leg gait?
Short leg gait means when the patient walks, he would tilt towards the ipsilateral side.
What do you mean by ipsilateral?
The short limb side.
But we are, like you said, you're right, you're very right. But if you keep to the same nomenclature, when the patient stands on the affected hip, the only way he can get that hip down to get his foot plantigrade is that pelvis dips down. You agree that's what you're trying to say?
That's true.
Yeah, that's what you're trying to say. So stick to the same nomenclature. When the patient stands on the affected hip or the bad hip, the pelvis will droop down on that side. and that is called a short leg, which is exactly the opposite of a Trendelberg. Yeah, so that's your short leg. Fifth one,
high stepping gait.
Yeah, so high stepping gait is in
foot drop.
Foot drop. Yeah, so you have to have a high clearance. And now, Firas, can you have just let's finish this. You're doing well. What are the three other cerebral palsy gaits?
You got a scissoring gait.
Yeah, good. One, scissoring.
In cerebral diplegia, then you get crouching gait.
Yeah, and third, wind swiped. Okay, for everyone. So I'm just giving you little gait patterns because so if you get a difficult patient, you just say these gait patterns. Yeah. So we finished the 5. So there are 5 orthopedic gaits: antalgic, Trendelberg, bilateral Trendelberg, short leg, and high stepping. Yeah, or foot drop. Then I divide my mind into 3 cerebral palsy. Will be scissoring, where you have tightness of the adductors. Second will be a crouching, and that crouching could be flexion of the hip, flexion of the knee, with or without equinus at the ankle. Clear? And then you can have a wind swiped. Wind swipe means flexion on one side and valgus on the other. Yeah, so wind swiped. And just to finish, 2 or 3 neurological gait patterns, common neurological gait patterns. Carry on, Ranjit. Parkinson's, what is a gait in Parkinson's?
You get a stiff gait, a short step gait.
Yeah, short stepping gait or a shuffling gait. Yeah. Second is a circumduction gait in hemiplegia. Yeah.
Okay.
And then what do you get, which you're going to get in a spine case? What is a common spine case going to be?
It's going to be a just prolapse with.
Yeah. But what do you get? What if you get a posterior column sign problem? What will the gait of a posterior column problem be?
A proprioception will be lost. So will.
Broad base gait. Okay. Yeah. So this is what I'm trying to say is we all know it, but if you can identify it for a patient, we are very confident now. So you have 10 gaits. So you're really looking forward to a lower limb. It could be spine, hip, knee. You're going to say it in any course you go to now, in any exam you do now, say these are the gaits. I don't think there are any more gaits. Firas and Shwan, any more gaits you want to talk about which are common?
No, that's pretty much covers everything. The reality is, if you're short, if you can't get the words, just describe what they're doing.
Yeah, absolutely. Yeah.
So I have a question, please. So in the gait, you just name what gait it is and then move on. That's all that's required.
I'm most of the time, if it's a very clear gait like an antalgic or a Trendelberg or a foot drop, why don't you just say what it is? Then if I ask you, or Shwan or Firas ask you as examiners, explain it. Otherwise, move on. Control it because it's your intermediate case. You've said it and you've moved on. That's what I'm trying to tell all of you. This is the only time when you actually have control. And if you don't take that control, you're opening yourself. So take the control, say, yeah, this is it. You got to antalgic, please lie down, and then charge towards him and do the lying down examination. So therefore, there's no chance of him to ask you anymore. But if you stutter and this guy is walking around in his underpants, they're going to ask you something more. You see what I'm trying to say? Yeah. So you control it for that time.
I just want to say, yes, absolutely. It's your station. You need to control it. The examiners might not always guide you through. And if you say something about gait and they drag on about gait and gait,
yeah,
you're not going to pass that because you still have to do all inspection. You have to move. You have to feel the joint. You have to discuss the management. You have to do all of that. There are tick boxes for each one of these. In intermediate, if it is a short case, it's possibly just about gait. It could be. But intermediate case will never be just about gait. If you're stuck on gait, you're not going to get anywhere. Even if the examiner wants to keep talking about gait, you try to move on.
Yeah, absolutely.
Yeah,
hi Walid. How are you?
Hi, Mr. Mahaluximavala.
Yeah. You treat this like as if you are in the real exam, yeah?
Okay, so Walid.
Take it seriously, yeah?
Yeah. So, Walid, now you're on to, just to recap, you had finished your gait pattern and now you've told the patient to lie down. As you want to ask you, I know you've done it with me before, but do you want to do sitting next or you want to do lying down next? What will you do next for everyone?
So once the patient, yes, his varus knee partially improved after lying down.
No, do you want to do lying down or do you want to do sitting? You know, do you want to make the patient sit and do sitting tests or do you want to do lying down?
No, I would like is he's more probably he's comfortable by sitting like that. So I would sit him like that. In his case, lie down flat.
No, what I meant is that do you want him to sit on the side of the couch, or do you want him to lie down?
I would prefer him to lie down.
Yeah, lie down. So just what I'm trying to tell all the other candidates is that at this stage, there's always a controversy that when you finish your gait, people make the patient sit on the chair, or they make the patient sit on the side of the couch, and they do sitting test next. Is that right? Walid, most people do that. My advice to everyone is that sitting tests are only important for mainly patellofemoral. They are very difficult tests to do. And in my eyes and in my way of doing things, I put it under special tests. And a 70-year-old man, you're not going to get much information from sitting. So I advise that do sitting later on, all right? So let's all agree that we lie down and do the lying down test next. And what Walid was trying to say, if it's a knee, the patient does not have to be flat as a pancake. He can be sitting up comfortably with some pillows, but he's on the bed. So now Walid, he is now lying like that. You can see the knee. I know it's difficult for you to do palpation now, but what are you going to say? How are you going to start now?
So my first phrase, his varus knee is improved.
Yeah. Or remain the same. So thank you, Walid. So for everyone, all the other candidates, write this down. As you notice, the minute you finished your gait and you make the patient lying down, your mind goes into a blank. You agree? Your mind goes into a blank. That's life, because you're doing something different. So you have to have some phrases which make you kickstart your mind. So for the knee, the best phrase which you just go on is that there's only one inspectory finding which will change by lying down to standing. And what is that? Is your valgus or varus. So when the patient lies down, just look at him and say, yes, the varus of his left knee has improved, or the varus of the left knee has remained the same. That kickstarts your mind. And next we'll go on to what? So what do you want to do next, Walid? Tell me what and I'll do it for you.
No, I'm going to touch your knee by the back of my hand.
Yeah. So what are you looking for next? Temperature. Yeah. Okay.
Yeah.
So now this is difficult. What I would like now is the time where if we were in real life, you as a candidate, Walid, would have been actually doing things. You cannot do it to this patient. So in your heading would be temperature. Is that right, Walid? That's what you're saying?
Yes.
Yeah? Okay. So for everyone, what I would do is I would say, thank you very much. And I'll tell the patient, and this is what I'll do. I'll put both my hands like that. Thank you. And if the knee was warmer, I would tell the examiner, the left knee is warmer than the right. Clear, Walid?
Yes.
So at the same time, now we have this controversy. In inspection, we decided how much to talk and not talk. Now when we come to palpating, which we are going to start now, let us be very clear that don't listen to people who have told you, go on talking. You cannot do both things correctly at the same time. And please decide, all the candidates, are you talking to the patient, or are you going to talk and verbalize a statement, right? But at no times are you going to mumble about anything. So if you're going to talk to a patient, so I'll tell you how to do it. So Walid, you're doing temperature first, and you're going to make a statement, the left knee is warmer than the right. Next, Walid, what do you want to do?
Now, I'm going to bend your knee.
Yeah.
I'm going to move your knee. Let's bend it together.
Bravo. Fantastic. So I'm doing that for you, and you over there. Okay, that's right. Now, what do you want to do?
Now, I'm going to feel around your knee where my finger is. Is that sore?
Yeah, good.
Now, I'm moving to the inside of your joint. Is that sore? Yes, that's fine. And what about, the medial ligament, the femur attachment, the midline here?
Good. That's right. Very good. You carry on. I know it's difficult.
That's brilliant. What about the outside of your joint? This bone is that hurt?
Yeah.
Yes, fine. What about the back of your knee? Is that sore? Now, I'm going now to move your knee. Let's straighten it together. I'm going to move your kneecap outside, feeling underneath. Is that sore?
No. Okay.
Now, finish. Now I'm going to move it in. Is that so?
Yes, slightly.
Okay. Walid, fantastic, Walid. Thank you very much. Just for everyone, what I've done and what Walid has very clearly demonstrated, that you all agree that his focus was who? Who do you think his focus was? He was completely the patient. And I want all of you to realize that there's only one important person is like Walid was completely bothered about only the patient. And in palpation, especially for tenderness, there has to be a complete rapport and the talk has to be with the patient, okay? You have to, now, so let me just recap how I will do it, which Walid did. So for everyone, if you are going to move a limb, it could be the knee, it could be the hip, it could be the shoulder, where you want the hip or the knee to be, then you tell the patient, we will move the knee together. Happy with that? So I'm going to tell the examiner, the patient, I'm just going to bend your knee. Let's bend it together. Okay. Okay. So this means he's not fighting you. I don't want anyone to do any palpation of the knee in an extension. It has to be done in a degree of flexion. All right, Walid, do you agree with that, Walid?
Yes, yeah. Sure.
Now, I divide my palpation into 3 parts. There's a front of the knee, which is your anterior aspect. There's a medial, there's a lateral, and there's a back. So let's repeat again. There's an extensor mechanism, there's a medial, there's a lateral, and the back. So I'm going to start by telling the patient, please let me know where my thumb is. I want to be very clear. So, and what am I pressing here, Walid? Is the tibial, is the front of the knee, which is the tibial tuberosity. Yeah? Right?
Yes.
Then I move up, and I'm feeling now, just for everyone, this what I'm feeling is the distal pole of the patella, suggestive of patella tendinitis. Okay? Then I go up and I feel the top of the patella. What is that for, Walid?
The quadriceps insertion.
Yeah, so what is that for? What is the diagnosis? It'll be quadriceps tendinitis. I'm looking for clinical scenarios, you see? And then if I feel a gap, I'm going to say there's a gap palpable, which could be an old quadriceps rupture, which is a common short case, right? So if I'm starting in the front of the knee, Walid, tuberosity, just for, this is for everyone. Is that sore? No? No. Is this sore? No. Is that sore? Yeah. And oh, there's a gap there. You see what I'm trying to say? I've got that part done. Then, because the camera is facing here, I next go medially, but let's do laterally. Let's see this. Is that so? Can you see that well, Firas? Are you seeing that?
Yes, yes, very clear.
Is that so? No. And is this so? No. And then this bone is important for me. Is that, what am I indirectly telling the examiner, Walid? Is the fibular head.
The lateral collateral ligament
attachment. Correct. And is that so? No. No. So what have I done? So on the lateral side is the anterolateral, mid-lateral, posterolateral, fibular attachment of the ligament, and the femoral attachment. And then the same on the inside. Let's do the inside. So what am I doing here, Walid? Anteromedial? Yes?
Yep.
Mid-medial and posterior. And then the attachments of the collateral here and there. So see how particular I am about the tenderness. And then, not bad there. Thank you. And then I straighten the knee, and just so you can see what I'm doing. I'm going to move your kneecap. Just tell me where my finger is. Is that so? I'm checking the lateral facet. I'm moving your knee inwards. With my finger, is that so there? Yes. That's the medial facet. Yeah. So we've done tenderness. And it's really so thorough, it'll 20 seconds and you've done. Okay.
As you do it slick way, but Mr. Mahaluximavala trying to show us a certain pattern that could be reproducible easily for everyone.
And thanks for that, Firas and Swan. So now we are on to the next part, which is we've done temperature, we've done tenderness, right? Now, what in your heading is going to be next for you?
So the next thing will be, I will go for look, feel, and move then.
Yeah, so you've done your look, you've done your feel, and you're going to go movements, right?
Go for move, yes.
Okay. Now, remember, Shwan raised a very important point. What did Shwan say? He said something very correct, that he would do swelling tests before tenderness, and he did it for a particular reason also, that if you're going to do movements next, a large swelling may impair maybe the cause of why your movements are not correct. So now is the time, unfortunately, Shwan, where I would do the swelling tests, you see. So I've just changed it one, not for any reason, just to be slick, so it's easier to do the tenderness first. That's all.
That's true.
Yeah, so Amjad, I would advise you before move, let's do swelling tests, all right? Okay?
Yeah.
So imagine, let's bend up the knee now. Or now you take control. You tell me what you want to do for the swelling test. What do you want me to do? And I'll do it for you.
For the swelling test, can you leave your knee flat?
Okay, so it's down now. Now, what do you want me to do now?
Thank you very much. Now I'm going to see the looking for the from the top to hold the suprapatellar pouch.
Okay.
Exactly.
Yeah.
So, and then I'm gonna swipe from the medial aspect.
Yeah. There.
Sorry, yes. And then I swipe from the lateral aspect, and then see the bulge on the medial aspect.
Fantastic, fantastic. What do you want to call this test?
This is sweep test.
Yeah, right. So very good you said it like that. And I'm telling everyone that all these tests, you can call it swipe test, you can call it filling test, you can call it whatever test you want, they're all the same. The principle is, and I'm telling you, Shwan, what I see happening very often is that when you ask people to do these tests, Amjad said it very right what he would do, but I'm telling you, I see everyone doing this. They come there, they're very stressed, they start doing this. They start just, massaging the knee in different directions, not really doing it with any purpose. So let's all do this test together. Just watch. The first thing for this test is, what am I doing? I'm making sure that I get all the fluid into the knee. Yeah, so my hand is on the quadriceps, right? And pushing down on the suprapatellar pouch. Amjad, all right?
Yes, correct.
I don't want your hand cannot be stabilizing the patella, right? Because otherwise the patella does not move. Clear? Right?
Yeah.
Now, when you did your test, right? What is a swipe test important for? Is it for a small effusion or moderate effusion or a large effusion?
It's for small and moderate effusion.
Yeah, so but most of the time it's for small one, and you agree it's a difficult test to do. So my advice to you, Amjad, is let's do the patella tap test first. Okay?
Okay.
So when you do a patella tap test, guide me through, same thing. So my hand is here, yeah. Stopping
So,
the patella pouch, yeah. And then what do you want?
So then I just push on the patella and tap on the patella.
Like I'm doing now. Can you see it? I'll go on the other side. 1 minute.
Yes, that will be better. Thank you very much, Mr. Mahabak.
Is it better now for us?
Yeah.
Yes, we can see now clearly. Sorry.
Suprapatellar pouch, not holding the patella, but here, my hand here, and that, right? Okay, and
that's it.
So that's your patella tap. My advice to everyone is just do patella tap first. So you're going to do it. Imagine if it's positive. I want you to verbalize it. So you're going to tell, but before you do that, are you going to tell like Shwan said? Are you going to tell what are you going to tell the patient?
So I will get a resonance. So in this test, I'm going to hold your leg from the top there. Let me know if I cause you any pain. Okay.
Yeah, just tell me I'm going to hold your thigh. And
I'm going to tap on your kneecap.
You don't have to say so much. That's what I'm trying to tell you now. You don't have to go so much into detail. Just say I'm going to do a test. I'm going to hold your thigh and let's do that. Okay. Now, if it's positive, I want your hands to be removed from there. So I don't want you to just go on doing this, and I don't want you to look at the examiner, because who's the most important person? The patient, right?
Yeah.
I'm looking at you now because I'm seeing the screen, but otherwise I would do this. Thank you very much. Look at the examiner and say patella tap was positive. Right, Amjad? So I want that manner to be done. So your first focus is on the patient. You finish the test, your hands are away. Look at the examiner immediately and say patella tap is positive. All right?
Okay.
Now, imagine if the patella tap was negative, you are forced to do your next test, which is your swipe test. For that, I'll do again. I don't keep my hand there. I'll tell the patient, Mr. Mehta, I'm just going to do one more test. I'm going to squeeze your thigh, right? Then, in my mind, I just move, see what I'm doing. I move the leg outwards, so my eyes are looking at the medial side of the knee, right? Then, what do? I empty the medial side like this, very clearly. And then you can wait for it to fill, which is called the filling test, or you can help it along by swiping on the outside. Is it very simple to do? Right? Like you said, is that correct, Abdullah?
Yes, that's exactly what.
Okay, so just for everyone to repeat, the simple way of doing it is Squeeze the quadriceps, get the fluid into the suprapellar pouch. In your mind's eye, this is moving a little, so you're going to see there. Empty the inside and help along by swiping on the outside. And that's your filling test. And the third test is the inspectory finding. So, Anil, what I would have said, suppose it was a short case, like you remember Firas said that suppose they sometimes focus on a short case only on swelling, for example. What is your first inspectory finding of a swelling, of a small swelling? What would be the inspectory finding of that?
So is swelling or wasting?
Yeah, you can, the word would be that when you bend the knee like this, and you're looking from the front, you will say there's obliteration of the furrows on either side of the patella tendon. You see? Isn't that a small subtle sign of a swelling? Yeah. So repeat it.
Yeah.
So
there's obliteration of the furrows on each side of the patellar tendon.
Or you can say there's fullness on either side of the patellar tendon. Use whatever phrases you all are happy with, but stick to one phrase. Yeah.
Okay.
And then you will say, thank you, Mr. Mehta. I want to keep your knee straight. And then you do your patella tap. Then you do your swipe test. Clear?
Okay.
Yeah, lovely. Good. So you see, we've spent so much time, but what me and Firas and Shwan have tried to do is try to say, forget about textbooks, forget about videos. It's whether it comes out of your mouth, the correct words, and whether you can control, right? Which you have.
It's the principle, isn't it? Obviously, you could have books about clinical examination, but this is how you should perform in the FRCS exam. It's very specific. Can I ask you, Mr. Mahaluximavala, they've been asked about examining the normal limb in the exam.
Yep.
For comparison. I know the books say this is the standard way of examining. You examine the normal limb. But again, this is exam-specific scenario here. Yeah. And in exam, I think if you start examining the normal limb, they'll have no time left to examine the...
Yeah, Firas, I agree. And I like this is a common question everybody asks me in my course. And I can tell you, guarantee that why are you worried about things which are not a worry for the examiner? Truly, they're worried for some reason. Every candidate is mortally worried about that. But like we've said, if you start doing what we've done, so let's say you start on the abnormal, on your bad leg, like we've done for tenderness, and we moved on, there's no place so far of doing anything to the normal limb. You agree, everyone? I mean, there's no place. When we have to do things like ACL, which we'll come to next time, then I'll tell you how I do it. And that's the only time when you may have to compare. And that's the time when all of us can chip in as to where should we compare or not. Yeah. But for normal things, no. And even for ACL, I would do the abnormal limb. And if it is positive, I know it's positive. You know, I don't have to do the abnormal limb. So the answer is, direct answer is just forget about the normal limb. Concentrate with perfect technique on your bad limb. And that's enough. Nothing more.
I think that's what also Shwan answered on the chat, isn't it, Shwan?
Yeah, absolutely.
I think it's a case by case, isn't it? It's pattern thinking.
Yeah.
In the exam.
So to my thinking, there's only one useful reason to examine the other side in a 5-minute examination. It's to compare if you've got an abnormality which is bilateral or not. So, for example, PCL rupture, ACL injury, ligament injury, you're comparing what is the normal side for that patient to the other side.
Absolutely.
That's all it is.
So please tell the candidates that don't worry about it. It's not an issue whatsoever.
I mean, if you would compare anyway during your inspection because you need something.
Exactly.
But for clinical examination, again, pattern thinking. If there is a patient, I think mainly ligamentous problem. If there are young ladies, they're thinking of ligament laxity or hypermobility, then yes, examine the other limb. But otherwise, I don't think, for example, question on how much we talk to the patient or how much we talk to the examiner while doing this.
Yeah, very clear on this. So let's all, Mustafa, it's a very common question. As we've said, in inspection, we have to say something, and I've given you the 3 phrases to say, right? And that could be anywhere in the body. So you were talking about a deltoid, you'll say there's swelling in the deltoid region or supraspinous wasting, etc., and deformity, etc. You'll say all that. You cannot keep quiet, you agree? You have to talk. The problem happens when you are doing tenderness. In tenderness, as Swan and everyone else says, we will be concentrating on the patient only because that's the most important person. So you have to have a complete rapport with the patient. Does it hurt here? Does it hurt there? Does it here? And do not try to tell the examiner while you're having a rapport with the patient that you have a medial collateral tenderness, lateral. You're going to get it completely wrong. Just finish your tenderness with a complete focus on the patient. Then look at the examiner and tell him he had medial joint line tenderness with collateral tenderness, and then move back to the patient, again the focus. I'm telling you that is probably the most, for an average person, but all of us are average. None of us are people who have these skills where we can talk and do everything perfectly. So for average person, the only way you can execute a correct tenderness is to rapport with the patient and then look at the examiner and tell him where your tenderness is. When you go to special tests, once again, the most important is do the test with a rapport with the patient. Just tell him, I'm going to hold your leg, do your collateral, and then I drop the leg and then tell the examiner that there was a laxity of the collateral ligament. Trying to explain the test at the same time as doing the test, 90% of people will get it wrong. If you can get it perfect, it's fine. If you get it wrong, you're going to get it wrong. That's my advice.
Not only will you get it wrong, but you'll miss the non-verbal cue the patient is giving you.
Absolutely.
So if you're trying to tell the examiner the collateral ligament is, and you're still palpating it as you're looking at the examiner, you've missed the patient's face.
Fantastic.
The first warning sign the patient is in pain.
Thank you, Sean. And I'm telling you, all of you'll go to a number of people will tell you that they're not wrong. The gold standard is to do everything, but we don't have the skills to do it. And like Sean said, you're going to miss the important points. So please accept. Do the test with a patient and then look at the examiner and tell him your result. Okay? You agree? Should we give it that format from now onwards, Sean and Firas? That's the way. Yeah.
That's very good. That's good. Very good way. And we could use the same methods in examining other joints also.
Absolutely. Absolutely.
Just going through the knee in a lot of details, step by step. So I think we covered the history in details.
Yeah.
We covered the inspection, gait, shoe examination, and palpation.
Swelling.
And the swelling, yeah. Swelling, yeah. Checking for the swelling and the fusion. So that's all covered now with the knee. We obviously still more to do with the knee examination.
Yeah. Movements, next time will be movements and special tests, and we are done.
Yes.
And that'll be one session. And then we can have other sessions to reinforce this. For example, one of you can do, shoulders, I can do hip again, things like that. So we cover clinical.
We had 67 people registered for today. Thanks everyone, particularly to those who came forward to talk. And I hope I'm sure you will all benefit from this in a way or another.
Academic